Good morning and welcome to the National Hispanic Council on Aging's Legislative Breakfast. My name is Christina Perez Jimenez. I'm NHCOA's Director of Programs at the National Hispanic Council on Aging, and it's my pleasure to moderate today's virtual event. Thank you for joining us. For over 50 years, NHCOA has worked to improve the lives of Hispanic older adults, their families, and caregivers. NHCOA's Legislative Breakfast is an opportunity to present important information on the key issues facing Latinos today before members of Congress. Today's Legislative Breakfast will feature a panel of experts and voices from the field talking about healthcare access among Latinos, the release of the cardiovascular disease findings from a new research study conducted by us at NHCOA, and also obesity among Latinos. Before starting, we would like to thank Nova Nordisk for sponsoring this event. So to begin the virtual event, it's my pleasure to introduce Dr. Yanira Cruz, the President and CEO of NHCOA, and one of the nation's foremost advocates and spokespersons for diverse older adults, and has been recognized for her commitment and leadership on behalf of diverse older adults nationwide. Welcome, Dr. Cruz.
Thank you. Thank you, Christine, and good morning, everyone. Welcome to all the participants for connecting, and thank you for connecting this morning. I also want to take this opportunity to acknowledge and recognize our presenters for today, Dr. Serrano from LULAC, who will be speaking with us today, as well as Dr. to be Christina Pacheco, soon to be doctor. She will also be speaking with us, and Bob Blancaro will also be making closing remarks. So thank you for taking time out of your busy days and connecting with us. So this is just a great opportunity to be able to mm, bring forward these key issues that are important to us. And by gathering here today, we are reaffirming our commitment to the well-being of our communities, especially our older adults who remain vulnerable and in need of our support. As we navigate what are obviously changing times, it is our duty to stand firm in protecting key programs, especially programs that serve as a vital resource for millions, such as Medicaid, which is front and center this week, Medicare, Social Security. These programs are integral to the good health and prosperity of Hispanic and Latino communities. As a matter of fact, nearly 10% of Medicare beneficiaries are Hispanic, and nearly half of Hispanic adults in the United States live with obesity, a chronic illness, as we know, connected to many other debilitating illnesses and conditions, which require comprehensive treatments and care. And in 2019, adults living with obesity spent more or less an average of $1,861 more per year on Medicare on medical care per person than individuals who are not obese. Individuals living in communities of color are also more likely to live in areas with less access to affordable and nutritious food options. And so please note that these programs are not just policies. They are promises made to the people of this country who are in need. These are promises of dignity, promises of security, and access to the care that our loved ones and elders have earned through hard work over a lifetime. And as we discuss health equity, we must acknowledge that chronic illnesses disproportionately impact Latinos and Hispanic communities. And to ignore what has been confirmed by research and the personal experience of millions is to regress as a society. These illnesses include diabetes, cardiovascular disease, cancer, and others. They leave countless families in dire circumstances, facing immense challenges compounded by a lack of access to proper nutrition or health care or housing. These challenges can be eliminated, but only with solutions that are well informed on the circumstances unique to all communities. It's on all of us to advocate for these important programs. But such advocacy doesn't end with calling your legislators. It has to continue with our communities. And in order for us to stand united for the resources and programs we need, we must ensure that our communities are educated and aware on the issues that impact them and the ways to ensure their good quality of life is maintained. It starts with us, within our families, our neighborhoods, our communities. And now more than ever, we must remain united. Yes, we must remain united. And as we continue this journey, I urge you to remain in contact with us, with the National Hispanic Council on Aging, NHCOA. Please stay informed, get updates from us, and stay engaged in meaningful conversations. Ask questions about the issues affecting our families, affecting your communities. And keep in mind that we're here. We have a resource center that you can call and talk to us in English, in Spanish, in Portuguese, and ask your questions. And that number, grab a pen and please write this number, the 202-658-8664. That's the number to our resource center. And so by using our services, you will get assistance with your healthcare needs, your advocacy needs, and much, much more. So we are here to connect you with any and all resources available to all of us. And I would be remiss not to invite you to become a member of our, membership program at NHCOA, our network of members. And there, by becoming a member, you remain connected, you remain engaged and informed through all the mechanisms and newsletters and information that we put out on a regular basis. And there's a QR code right in front of you right now. If you click on that, if you take a picture of the QR code, you will be directed to the membership page. So please join us. We want to make sure that we are communicating accurate, science-based, and timely information out to you. So please stay connected with us. And lastly, let's not forget the importance of self-care. In these moments of change and uncertainty, taking care of ourselves physically, mentally, and emotionally is absolutely critical. I want to ask you to please prioritize your health, take time off to rest, and seek support when needed. It's important because in order for us to take care of our community, to take care of our loved ones, we have to first take care of ourselves. We have to our health has to be well kept. So please make sure to keep that in mind and take care of ourselves, self-care. And lastly, let's stand together, united in purpose and stronger than ever. You're not alone, and we're not alone. Muchísimas gracias. Enjoy the rest of the webinar. And I turn it over to you, Christine. Thank you.
Thank you, Dr. Cruz, for your wonderful remarks. So now let us begin today's virtual legislative breakfast. Latinos in the United States often face significant barriers to healthcare access, including language barriers, lack of insurance, and limited culturally competent care, among others. Many Latinos in the U.S. find employment in positions that do not provide healthcare benefits, making it much harder for them to afford medical services. Immigration status can also impact healthcare access, as some people may avoid seeking care due to fear of deportation or related legal concerns. Ensuring healthcare access for Latinos is essential for improving overall public health by reducing health disparities and preventing chronic illnesses. So our first speaker is Christina Pacheco, NHCOA's Director of Policy and Development. Today, Christina will speak more on healthcare access among Latinos. Welcome, Christina.
Thank you, Christine, and it is a pleasure to be here with you all this morning. If we can put my slides up, that would be fantastic. Okay, next slide. So Hispanic and Latino Americans are not only a significant part of the U.S. population, they are one of the fastest growing demographic groups. In 2023, roughly 1 in 5 people living in the United States was Hispanic or Latino. By 2060, more than 1 in 4 people living in the United States will be Hispanic or Latino. This rapid growth highlights the urgent need to address the unique barriers to healthcare access, such as language differences, cultural nuances, and economic challenges. Improving healthcare access for Hispanic communities isn't just about equity. It's essential for enhancing public health nationwide. By investing in culturally and linguistically tailored services and policies, the healthcare system can better meet the needs of a diverse, expanding population, ultimately reducing disparities and improving outcomes for all Americans. Next slide. This map illustrates where Hispanic and Latino populations are most concentrated. In areas like New Mexico, California, Texas, Arizona, Nevada, Florida, New Jersey, Colorado, and New York, these regions fall under states with different Medicaid expansion statuses under the Affordable Care Act, which plays a critical role in healthcare access. In many states, such as New Mexico, California, and New York, Medicaid expansion has improved access to affordable health care for low-income Hispanic individuals. Conversely, in states like Texas, Florida, and Kansas, where I'm currently located, the lack of expansion has left many Hispanics without affordable insurance options. This policy divergence creates an uneven landscape where Hispanic communities in non-expansion states face higher uninsured rates and more limited access to necessary services, compounded by language, cultural, and economic challenges. Understanding these regional dynamics is key to developing tailored solutions that ensure all Hispanics, regardless of where they live, can access quality, affordable health care. Policymakers can pursue several strategies to close these gaps for our communities between Medicaid expansion and non-expansion states. Strengthening initiatives for preventive care and chronic disease management that directly address the health challenges faced by Latino communities is just one way. Targeted outreach programs and health education campaigns in Spanish can also improve outcomes. Involving Hispanic community leaders and advocacy groups like NHCOA in policymaking processes to ensure that reforms are tailored to specific needs and challenges of these communities is key. This collaborative approach can lead to more effective, context-specific solutions. Next slide. In 2022, the data revealed a stark disparity in health insurance coverage among different ethnic groups. Approximately 16.8% of Hispanic and Latino individuals were uninsured. This is nearly 3 times the rate observed for non-Hispanic whites. This significant gap underscores the persistent challenge that Latino communities face in accessing affordable health care. Despite some progress over recent years, multiple barriers continue to impede healthcare access for our communities. Economic factors such as high deductibles and steep out-of-pocket costs play a major role. Additionally, difficulties in finding a suitable doctor further compound these challenges. For many, these barriers are intertwined with issues related to immigration status, although not all obstacles are attributed to that factor alone. The experience of healthcare is not uniform within the Latino community. For example, Hispanic Americans who identify as Black report a higher likelihood of encountering negative healthcare experiences. Similarly, younger Latino adults are more prone to have faced unfavorable experiences when seeking care, indicating that age and intersecting identities can further influence the quality of care received. Next slide. This chart highlights several key risk factors that disproportionately affect Latino communities compared to non-Hispanic white populations. Notably, nearly 7 in 10 Hispanics speak a language other than English at home, a significant language barrier that can impede access to health information, patient-provider communication, and navigation of health systems. Additionally, over 1/4 have less than a high school education, which can limit health literacy and reduce employment options that include health insurance. The data also shows higher rates of poverty and food insecurity among Latinos, both of which introduce daily stressors and can further discourage or delay health-seeking behaviors. Altogether, these combined challenges make it more difficult for many Hispanic individuals to secure consistent, high-quality health care, underscoring a need for targeted interventions and culturally competent care. Next slide. A recent Pew Research Center survey conducted in 2021 of 3,716 Hispanic adults explored their views on science, including interactions with healthcare providers, science, technology, engineering, and medicine education, trust in scientists, and science news engagement. Insights from 6 virtual focus groups and expert advisement highlighted the diversity within the Latino community, especially differences in nativity and language proficiency, which is central to shaping these experiences, particularly as it applies to medical care. Hispanic American respondents highlighted several key factors. Overall, roughly 53% believe that working in a high-risk job is a major contributor to poorer health outcomes, emphasizing the impact of occupational hazards. Nearly half also pointed to limited access to quality local medical care as a significant issue. Communication challenges, including language and cultural differences, were cited by 44 participants, underscoring the importance of effective interaction in healthcare settings. 40% identified pre-existing health conditions as a major factor, while fewer respondents viewed differential treatment, such as provider bias or lower prioritization of Hispanic patients, as major contributors. Together, these findings illustrate the complex and multifaceted nature of health disparities in our communities. Next slide. Culturally concordant care is important because it allows patients to receive health care that aligns with their cultural beliefs and practices. leading to improved communication, increased trust between patient and provider, and ultimately better health outcomes, especially for marginalized populations, by mitigating bias and promoting a more personalized care experience. Essentially, when a patient feels understood and respected based on their cultural background, they are more likely to engage with their healthcare and follow treatment plans effectively. Nearly one-third of Hispanic adults prefer to see Hispanic or Spanish-speaking providers, yet only 7% of U.S. physicians are Latino, and 9% of all healthcare practitioners and technicians identify as Hispanic. This shortage contributes to communication gaps, patient discomfort, and potential biases, evidenced by the fact that 1/4 of U.S. Hispanics say they've received lower quality care, and over 1 in 5 report feeling treated with less respect than other patients. These findings underscore the need for culturally concordant care and enhanced Hispanic healthcare workforce. By increasing representation of Hispanic and Spanish-speaking professionals, and by training all providers in culturally competent practices, we can reduce misunderstandings, improve trust, and ultimately achieve more equitable health outcomes for Latino communities. Next slide. We have seen recent attacks on DEI, and these attacks have a profound impact on access to care. Disbanding of CMS's Health Equity Advisory Committee removes federal oversight on racial healthcare disparities. Medicaid cuts threaten coverage for low-income Hispanic families. Lack of DEI initiatives may hinder research on Hispanic health disparities, and rural Hispanic populations face increased difficulty accessing care. There are ways to enhance healthcare access for our communities. Protecting and expanding Medicaid and Affordable Care Act programs would help in one way because Hispanic Americans are among the largest beneficiaries of Medicaid and ACA subsidies, as they are more likely to work in jobs that do not provide employer-sponsored insurance. Cuts to these programs would lead to higher uninsured rates, delaying necessary medical care, and increasing reliance on emergency rooms, which raises overall health care costs for everyone. Funding community-based healthcare or health programs is another way to enhance healthcare access. Many Hispanic communities face geographic and financial barriers to accessing medical facilities. Investing in community clinics, mobile health units, and bilingual healthcare navigators ensures that preventive care, screening, and chronic disease management are accessible to low-income and rural populations. Nearly 30% of Hispanic Americans have limited English proficiency, creating communication gaps that impact diagnosis, treatment, and patient trust. Training healthcare providers in Spanish language proficiency and cultural competency would improve doctor-patient interactions, encourage preventive care, and reduce medical errors caused by misunderstanding. Many Hispanic Americans live in rural areas or medically underserved areas where healthcare facilities and specialists are limited. Expanding telemedicine services, including Spanish language virtual consultations and digital health literacy programs, would allow families to access specialists and routine care without the burden of travel and costs, or work disruptions. Hispanic and immigrant communities face implicit bias, citizenship-related barriers, and fear of public charge rules, which can deter them from seeking medical care. Strengthening anti-discrimination laws in healthcare settings, enforcing equal access regulations, and ensuring that mixed-status families can safely enroll in programs without immigration repercussions would create a more equitable system. These recommendations collectively reduce health disparities, overall healthcare costs, and improve long-term outcomes for Latino Americans. Next slide. Over the past decades, Hispanic Americans have faced persistent barriers to quality healthcare. Recent policy changes, including cuts to Medicaid, the dismantling of health equity initiatives, and the rollback of diversity and inclusion efforts, threaten to widen these disparities. These changes disproportionately impact low-income families, immigrant communities, and those in rural areas who already struggle to access essential medical care. Without action, we risk reversing the process or the progress made in expanding healthcare coverage and addressing systemic inequities. Community health centers, Medicaid programs, and culturally competent care providers serve as lifelines for millions of Hispanic families. Weakening these programs will only deepen healthcare disparities, leaving many without preventive and life-saving care they need. To ensure that healthcare remains accessible to all, we need policymakers and community leaders to take proactive steps. Protect Medicaid and ACA programs that provide affordable care for working families. Reinstate federal health equity initiatives to continue addressing racial and economic disparities. Invest in community-based health programs in Hispanic and underserved areas. Expand telehealth and language access services to ensure no one is left behind. And strengthen anti-discrimination protections so that healthcare remains a right and not a privilege. As a nation, we must commit to ensuring that every individual, regardless of race, income, or immigration status, has the healthcare they deserve. The future of Hispanic healthcare access depends on collective action. We must work together to protect our communities and uphold the fundamental right of health for all. Let's ensure that progress is not undone, families are not left behind, and healthcare remains a foundation of opportunity and well-being in the United States. Thank you.
Thank you, Christina, for your presentation. So to everyone, if you have any questions, we encourage everyone to type them into the chat box here in GoToWebinar. And at the end of the panel session, we will have a question and answer session between all the panelists as well. So at the National Hispanic Council on Aging, we are working to create a greater awareness about cardiovascular diseases and to improve access to screening for high cholesterol, lipids, and others. As part of this initiative, we recently conducted several focus groups to better understand Latinos' knowledge, attitudes, beliefs, and behaviors regarding LDL-C, or also known as the bad cholesterol, testing, treatment, and also the management. So today I will be speaking about NHCOA's findings of the cardiovascular disease focus groups. Next slide, please. And next one as well. Okay, so we gathered the opinion of 72 Hispanic adults about cardiovascular disease, particularly about LDL-C, or also known as the bad cholesterol. So we conducted 10 virtual focus groups that we did in California, Florida, New York, Texas, and also Puerto Rico. And in the next slide, we gather the participants' knowledge about LDL-C, and actually we found the differences between age groups. For example, participants age 35 and older were somewhat more knowledgeable on the topic. And in comparison to more participants in the age range of 18 to 34, that they admitted that they did not know much about LDL-C. And also some participants mentioned health topics that represented comorbid conditions such as diabetes and vascular dementia. Some participants recognized that cardiovascular diseases could be hereditary or acquired. And in the next slide, we gather the factors that contributes to LDL-C and actually some of the factors that contributed to elevated LDL-C, or also known as the bad cholesterol, was overall lifestyle, especially a sedentary lifestyle, diet, and exercise. They also pointed out that some components of traditional Latino diet increased their risk for developing high LDL-C. There was an interruption with the presentation, but we will get back to it. And then other factors that contribute to LDL-C was that they also identified the American diet, also meaning the US diet, that it's in the next slide, and eating out as also contributing to high cholesterol. And they mentioned the way they cook with the use of oils and lard for cooking. And participants correctly identified a number of foods that contributed to high LDL-C, including red meats, dairy products, sausages, fried foods, and foods that are high in fat, among others too. So for example, as you see in the picture, we have the pork and chicharrón, or also known as the pork rind in English, that were mentioned by a lot of participants. So in the next slide, we will talk about ways to reduce LDL-C. And participants focused on lifestyle related factors such as diet and exercise. For example, avoiding fatty foods and oils, eating in moderation, and eating a balanced diet. And also, two participants from Texas highlighted the importance of education as an important way to reduce LDL-C. And in the next slide, some participants also pointed out that some barriers to adequate physical activity are because of limited time and also given to sedentary occupations. Some pointed out that changing one's mentality is important to develop lifestyle changes. And a few participants mentioned that consulting a doctor or taking medications were ways to decrease high LDL-C. So when talking about experience with high cholesterol diagnosis and treatments, well, in the next slide, some participants recognize that the first approach to lowering high LDL-C is diet and exercise, followed by medication. And a second approach mentioned is to use different homeopathic remedies that can support lowering high LDL-C, such as teas, herbs, omega-3s, vegetable, fruits, and others. And in the next slide, we'll talk about barriers to treatments. When talking barriers to treatments within the participants, well, many of them expressed frustration with time and economic barriers when implementing recommendations of a balanced lifestyle with diet and exercise. So they also highlighted other barriers, for example, lack of health insurance or the costs, the lack of education from healthcare providers, talking with them about high cholesterol, access to transportation to visit their healthcare providers, the fear, the hesitance to go to the doctor, and also the lack of education about the topic overall, especially by the healthcare providers. And in the next slide, we talk with the participants their experiences with step therapy requirements. And actually, most participants had never heard of step therapy before. And when we explained the term of step therapy, participants viewed the practice of step therapy as inhumane, unethical, inefficient, and not transparent. For example, participants thought that patients should be in control of making the decision about which medications they take, or should share this responsibility together and with their healthcare providers, for instance, and not the health insurance companies to make that decision. So when talking about prior authorization, well, several participants were familiar with the concept, yet there were also several participants that were hearing this term for the first time. And those that had experienced the prior authorization process, they describe it as some relatively like innocuous situations of having to change medications that the health insurance did not approve, while others describe inconveniences like adjustments to medication regimens for effective treatment of their condition. So, and also they experience a lot of major delays in needed treatments, waiting for the medications to be authorized by their health insurance. And lastly, we ask participants familiarity and also willingness to participate in clinical studies. And typically, they were generally familiar with the concepts of clinical trials since they had heard about it through, for example, their healthcare provider or have seen recruitment advertised on social media. For example, we had two people that had heard about clinical trials specific to cholesterol. And when we asked whether they would be willing to participate in clinical trials or not, well, more participants aged 35 and older were willing to enroll in a clinical trial. And while we had some younger participants that were more cautious in participating or not. And finally, if you want to know more detailed findings from the focus groups and national survey that we conducted regarding this topic, you can access the link here in the slide, or you can visit us in our website. And for more information about the report, it's available for everyone in English and Spanish. Thank you. Okay, so once again, if you have any questions, we encourage you to type them in the chat box. At the end of the panel session, we will review questions in the question and answer session. So let's go ahead with our next topic. So obesity has been well documented as a chronic disease that impacts a massive proportion in the United States population. From 2017 to 2020, the prevalence of obesity in the US was found to be 41.9%, and specific to the US Latino population, the CDC estimated 45.6% to be experiencing obesity. But due to heavy stigma across the country, many are hesitant to learn the truth about the risk of obesity and the treatments available for it. But let's hear more from Dr. Serrano, who serves as the National Director of Research and Policy at the League of United Latin American Citizens, or also known as LULAC. So Dr. Serrano will be providing an overview about the status of obesity among Latinos. Welcome, Dr. Serrano.
Thank you so much, Christine. I thank you to Dr. Cruz and the folks at NHCOA for the invite. So the issue of obesity for me has always been a challenging issue because there's so many factors that go into what it means for how this becomes an epidemic. And there's upstream and downstream factors, just looking at it from a public health perspective. But ultimately, we know that the fruit of it is a very costly situation whereby you have folks who don't have a lot of money, who have very, very costly health conditions that either puts them out of a job or puts them in a hospital bed, but with a lot of ailments. And so what I wanted to do is kind of give everyone an overview of what we're seeing with the issue of obesity, namely on the issue of how we're navigating this really, really big challenge in our community, and in a time when it's extremely tough in terms of policy, and then yet there's little glimmers of hope. And so I'm just going to take you through the kind of just the landscape of it, and then I'll take you through what the real challenge is, where the glimmers of hope are, and how we have to really be persistent and be vigilant about what's going on. So next slide. So as was mentioned earlier, Latinos, we are a growing population. We are about 1 in 5 people who live in the U.S., about 19% of the population, projected to be by 2050 to be 30% of the population. We obviously more in the Southwest and certain more in the coastal states, Florida, New York, New Jersey, but also like, Texas, California, New Mexico, Arizona. I'll say this, I grew up in Idaho, so probably not a place where a lot of folks think of Latinos being at, but we're almost everywhere. And I think the experience of folks being in places, it doesn't really, it should really kind of just remind us that like the struggle is very similar across the states. Um, so to give you a clue, Latinos, I sometimes joke that Latinos tend to be number one or over indexed for all the wrong reasons. We are the least likely to graduate from high school. We are the least likely to graduate from college, but we're among the most likely to get diabetes, to get hypertension, to get to not have healthcare coverage. So there's a lot of things that we just tend to be number ones for all the wrong reasons, and so it's a struggle when we don't have healthcare coverage. So we don't no health insurance means no usual source of care, which means not going to the doctor frequently, which means a lot of the ailments of chronic disease, they're just manifesting themselves in us, and we're getting sicker and sicker by the time we go in the hospital. Sometimes we already have a foot in the grave. And so it is a really, really big challenge. We're the second largest ethnic group in the country. And so sometimes that political force sometimes needs to be exerted, particularly on the issues of health and healthcare access. And so Medicaid expansion, for example, Latinos mattered a lot in terms of expanding Medicaid. Latino votes mattered a lot in terms of voting for certain people who championed the idea of extending healthcare coverage and not reducing the Affordable Care Act. So next slide. Okay. So again, as I mentioned before, we over-index on issues of cancer, cervical cancer, stomach cancer, liver cancer. We have higher rates in the general population of diabetes, obesity, hypertension, depression. Again, we tend to be a very like at older ages, we tend to be sicker, we tend to die younger. This is what got me interested in public health. So my background is I have my master's in public health, my doctorate in health economics and health services research. What really got me thinking a lot critically about public health was why is it that certain communities and certain people die younger than others? Why is it that like when Latinos seek certain care, seems to be by many standards very substandard? So what is it that's causing us to die 20 years, 10 years younger than the general population? So that was something that was just kind of a big factor like going into this. So again, when we think about the Affordable Care Act of 2010, that kind of got rolled out by 2014, 2015, we're seeing a massive increase of people getting healthcare coverage, which is a good thing, right? Finally, we see Latinos getting, it used to be in some places, like it used to be 50% of the Latino population was uninsured. To bring that down to maybe 30%, it's still high. 30% is still very high, but it's much less than 50%. But we're making some progress. I worry now that with the current changes to Medicaid, I think we might be going the other direction. We might be going back towards that 50%. So if you go to the next slide. So as Christine mentioned, like Latinos, we tend to we like obesity among the Latino adult population. So what you're seeing on the left in this graph is if you look at the Latino population, it's that last bar on every one. So the first one is the total, the middle one is males, and the last one is females. So the highest group of obesity is African American women, and it's at 56.9%. And second highest to Latino women. Um, uh, I think these numbers are actually a little bit older. Like the Latino women are now pushing almost 50%, and Latino men slightly lower than that. Bottom line is Latinos adults, about half of Latino adults are not overweight, they are obese. If you add overweight to that, we're about 80% overweight and obese. Um, Now, think about it this way. Let's look at the next generation. We have like Latino population tends to be a very young population. We have a lot of the Latinos in the U.S. tend to be kids. If you look at that, and hands down, the Latinos are dominating here. Unfortunately, again, they're number one for all the wrong reasons. Latino boys, instead of females, it's Latino boys now that are the most obese. Almost 30% of Latino boys are obese, followed by Latino girls. So we are, again, entering a space where we're about over 50% of our population is obese. And with that, it's not just, we have to buy new clothes, maybe you have to go to the big and tall store. It's more to that. And so if you go to the next slide, those folks that know me probably well, I don't like being a statistician and being somebody in public health. Like we do a lot with regressions and certain models and certain ways of understanding data. But I think data doesn't really matter until you tell a story with it. And sometimes the best stories are stories that you really know very well. So I talk about the idea about the $1 million patient. And what I mean by that is that obesity in many ways can be sometimes a key to unlock a really bad door, a room with a lot of bad problems. Um, my background in public health started with HIV. And I bring that up because quite often I think about obesity and I think of HIV. You wouldn't think there's anything in common between the two. But for me, it makes a lot of sense because in many ways, when you think about obesity, the first question people say is, how did they get that way? Oh, couldn't they have done something different? And it's the same thing with HIV. How did they get HIV? They must have been doing something wrong. And so it becomes a question of what the person did to get there, and not looking at it for simply a disease that we have to treat. And so the stigma that comes with it, that the person who is HIV positive and the person is obese does not want to speak out against it because in many ways they know they're going to get judged. So I give you an example of somebody who I know very well, my mother. Let me give you an example. So I grew up as a migrant farm worker in Idaho. I was born in the US. My dad was undocumented. He was from Mexico. Mom was from South Texas. Um, mom largely raised us on her own. She was pretty much a single mom by the time I was basically 10, 11. Mom worked two jobs. So she worked in the fields in the mornings and afternoon. So got up at like 5:30 in the morning. By the time it was around 6:30, she was already in the field working till 2:30, come back home, shower, and then it would be in a factory in the evening to get back home at 11:30 or midnight and start the process again. All I knew about mom as a child was just the lady just loved working. She worked 16-hour days every single day. That was her life. By far the hardest working person I know. And I still say that now, having met a lot of folks who are hardworking, but definitely in terms of the amount of the labor that she did to be working in the fields in the hot sun, to working in a cold factory warehouse, like not easy. But so hardly the word that least describes her is lazy. And so yet quite often when we think about obesity, we think of people being lazy. So two jobs, a family, and in the end, what you have is $1 million health expenses. And so how did we get here? So why I say this, because mom, like probably genetic predisposition, family dynamics, just health literacy, and also just simple poverty. I mean, she made too much money to be on food stamps, but quite often we would go to food banks, and so it was not the healthiest food that we got, and so that's what we lived off of. Of course, mom just wanted to put food in our bellies. That's all she cared about, and but unfortunately, by the time my mom was probably in her late 50s, mom's weight had got way too overbearing, and to the point by the time she was 58, she was about 535 pounds. And with the 535 pounds came the whole set of again, the key got unlocked, and there was diabetes, there was hypertension, there was sleep apnea, there was bad, like total knee replacements, there was the congestive heart failure, there was the cholesterol, there was the whole works of chronic diseases. So by the time she turned about 60, she was really $1 million patient, because it would take probably about $1 million to really treat her, to bring her back to some sense of normalcy. Next slide. And what I mean by that, the cost of treatment, a diabetic spends like, so we think of insulin, we think of this, but there's a lot of other costs that come with it, with having to miss work, having to just feel lethargic, to feel sometimes having to go to the emergency room. They're about 2.6 times higher than somebody who's not diabetic. Hypertension, for example, a quality of adjusted life years is about $23,000 versus the standard. It's much higher. It's much more expensive to be hypertensive to not be hypertensive. Depression, just simple depression, is just like the lifetime burden of someone with depressive disorder, or just depression, like is 1.5 million. Again, the amount of costs that come with it, of heart disease, high blood pressure, cancer, cholesterol. It's not just simply the cost of the medications. It's the cost of not going to work, the cost of not picking up your kids from school, and the cost of a lot of other things that get disrupted because of these chronic diseases. And what makes the difference between chronic and acute diseases is that these chronic diseases don't go away. They're here with you for the rest of your life. So again, I stress that because obesity in many ways is the gateway to get to this space. Next slide. So again, the big challenge is what is causing this? Like, how do we get here? So we think about it. Let's go upstream. We go upstream and say, okay, what is causing it? Is it the environment that people are in? Yes, part of it is. Is it the genetics? Yes, part of it is genetics. But the environment, think about it for Latinos. Like, Latinos don't, like, oftentimes, I could probably count on one hand how many Latino families that I know that go to planning and zoning commissions meetings. No one goes. They have these meetings to decide what they're going to put in certain neighborhoods, whether they're going to zone this as a commercialized neighborhood and allow McDonald's and Burger King and Wendy's and all these fast food places to come in and make it basically a fast food swamp. Or are they going to rezone it in a certain way that is going to have residential houses, or maybe the bus lines are going to be redirected. So in the end, the grocery stores close, and so now you have a food desert. And so you have that environment there where access to healthy foods is difficult. I remember a few years back during COVID, I wrote an article trying to argue that we should have SNAP benefits be online ordering, have people be able to order food online and have online or have delivery using their SNAP benefits, the SNAP benefits that they have, and how crazy it sounded when you pitched the idea. But during COVID, it mattered a lot because people who were disabled and old could not go into a grocery store just out of fear of the disease. So again, so you think about access, just the affordability and accessibility of where you can get healthy fruits and vegetables. Again, a big problem with our communities. A lot of the community lives in low, or who are low income. They live in poverty. They need sometimes SNAP benefits. They need sometimes the food stamps to basically supplement their income. Now, food stamps are not like completely as like a credit. It's not, people think it's a credit card where you can just buy food with it. It's in Maryland, for example, a neighboring state to here. It's not that cheap. It's like they offer $6 to $8 a day. And just to give you a clue, 2 blocks from here at Subway, their sandwich, if you could buy a sandwich with food stamps, is $6.75. You couldn't even buy your daily apportionment for food for one sandwich for that day. But what we're seeing now is a cutback on SNAP benefits. We're seeing the new administration and the Congress trying to somehow claw back on, in efforts to try to save money for the American taxpayer, is to try to cut back on SNAP benefits that in the end, I would argue, would actually increase the cost later on, because there's a cost of action and there's a cost of inaction. If you don't address food security now, you will address it later in chronic disease. And so what I've just issued here, I just showed you some of the headlines I've been making about Medicaid. So initially, the Medicaid was not going to be touched. But now the House Republicans are saying they're going to cut it by billions, and that's going to affect millions of people. So with people not having healthcare access and not having healthcare coverage through Medicaid, they're going to have now what? No usual source of care, no way of accessing a clinic. And in the end, they delay their treatment or delay even preventative care or some kind of screening. And so by the time they do come to the hospital and they come to the emergency room, they're in a really bad state, and they're a really expensive patient. So next slide. Next slide. Oh, there we go. Um, so I wanted to delve a little bit into these cuts to Medicaid because I think it should be concerning for all of us. When we talk about obesity, we're talking about a chronic disease, a disease that requires long-term maintenance of the person, a long-term interactions between providers and the patient. Um, and so when we're looking at right now some of the proposed changes for Medicaid, everything's on the table right now. So we don't really quite know what's going to happen, but everything seems to be on the table. There's the idea of proposing cuts. There's kind of this per capita spending for Medicaid that has been talked a lot about. There's the idea of switching them over to from 1115 waivers through CMS to having a block grant system, so where you basically the federal government just gives the money down to the states and say you decide what you want to do with it. I can tell you, I grew up in Idaho when they had block grants to try to rehabilitate North Nampa, my hometown, in my area. It was because we had no sidewalks, we had no street lights in the area where mostly Latinos lived. When they gave a block grant to put street lights and sidewalks for us, they ended up using that block grant to make a new rodeo stadium. To just give you a clue, sometimes when you give money out to the states with no strings attached from the federal government, it can be really misused badly, and sometimes it does not go for the truly targeted population. Time limits on coverage. It's hard to even talk about this without getting angry because, like, when you think about folks who are elderly, folks who are permanently disabled, how are you going to put a timeline on that? I have a brother who's completely disabled. To basically say, all right, Freddie, you're going to have to, you got 3 years to get better, man. Like, you've been disabled. You've been, like, basically, he has mild to severe or medium to severe retardation. To say he has got 3 years for healthcare coverage and then what? Like, he's going to get better? No, I mean, it's just ridiculous to think how this is in many ways very cruel. Um, Go to the next slide. A public charge rule. So again, this is something that they talked about last time. So Project 2025, I think we're starting to see, I think the Time Magazine has come out and kind of compared what was promised in Project 2025 with what we're seeing now. It's about 85+% of accuracy. Whatever they said in Project 2025 a year and a half ago is actually coming to full fruition right now. So just some of the things to just keep in mind. One of the things they talked a lot about is public charge rule. So if you are a legal permanent resident, if you have a green card and you apply for food stamps or you apply for Medicaid or you put your kids in Head Start, that's going to count against you when you apply for citizenship because now you're a burden on the country. And so what has happened when they have this public charge rule, a lot of folks don't apply for food stamps, don't apply for Medicaid, which means more people are uninsured. And again, you might save money on the short term, but in the long term, you're going to have really sick people becoming more expensive patients. Work requirements, again, it's hard for me to talk about this without getting angry because when you're having somebody who's permanently disabled, who is very elderly, to say, yeah, you got to work. You got to prove that you can work in order for you to be getting Medicaid. Medicaid is not a reward for working. Medicaid is an enabler for basic fundamental human right to healthcare. If health is a basic form of human dignity, then having access to healthcare is enabling that human dignity. To basically say it is now no, it's not a right. It has nothing to do with human dignity. It's a reward for working. It seems absolutely crazy to me. Because in the end, we will all be paying for this because EMTALA laws, like the emergency rooms can't turn people away. So they have to take people in. So those emergency rooms, like when they take people in, those hospitals have to take people in who are really, really sick. That bill comes back to us as consumers, as people who live in the population. So we will be paying it one way or the other. And discrimination enforcement, I just wanted to bring that up because in many ways, like we were making progress on language barriers and cultural insensitivity, particularly for folks who are living in like nursing homes and senior homes, where you see where they wouldn't have any staff members who spoke Spanish. Under the new guidance that was done during the Biden administration, they were changing Section 5057 to include language access barriers. Now the rollback of it now is to rule it back to strictly just race and ethnicity. Language doesn't matter, sexuality doesn't matter. So a lot of this stuff will be coming back in full fruition. So all of this stuff is to consider when we start thinking about the treatment and the access to care, access to healthcare coverage that matters for people who are obese. Next slide. Right, cool. So when it comes to obesity, so we know that half the adult population is obese. We know that 30% of Latino kids are obese. So the access to certain treatments, what we've seen in recent years, we've seen the rise of GLP-1s, anti-obesity medications that in many ways have actually helped a lot. They have reduced people's blood, like they've helped on the issue of diabetes. They've issued on weight control. Basically, it's an appetite suppressant, and it works. The problem is coverage. A lot of the people who have had to pay out of pocket, and the people who had to pay out of pocket, particularly direct your attention to the lower right. Is I'm looking at the 19% that paid the full cost by themselves, and then the 57% that the insurance paid part of it, and they paid the rest. These people are not doing it to wear, a swimsuit to go to the beach or to wear a nice dress. They're doing it just to simply stay alive, to simply avoid getting cancer, avoid getting hypertension, cholesterol, whatever the issues is, to actually save money for the healthcare system. So for them to have to pay out of pocket, even though they're the most poor, seems crazy. So when we go to the next slide. So the challenge has been to try to get some kind of solution. So there's been a big push. A lot of stakeholders across the country. It really of all ideologies, of all races, ethnicities, ages, regions. Everyone has come together, basically pushing for access to anti-obesity medications for Medicaid and for Medicare. A lot of the health insurance companies, there's a ripple effect when Medicare and Medicaid, especially Medicare, covers something. A lot of the private insurance companies follow that model. So the challenge is to get Medicare to cover these drugs. So it has been an ongoing fight to try to get Medicare to do it. We've had like TRICARE, we've had the VA, we've had federal employee benefits. They all cover anti-obesity medications, but Medicare doesn't cover it, and Medicaid doesn't cover it. Medicaid covers it in some states, but not in all states. And there's no national directive to get Medicaid to cover it in all states. So this has been the big fight that we had. Next slide.
Dr. Serrano, I apologize for interrupting, but due to time constraints, we have the panel question and answer session in a minute. So if you can wrap up, apologize for interrupting us again.
Sorry, I'll be quick. So one of the big challenges that we've been going around Capitol Hill, many of us have been going around to try to boost federal efforts for anti-obesity medications. The Treatment and Reduction of Obesity Act, TROA, was a huge bill. You can see here my little walking partners around Capitol Hill trying to lobby for this bill. We made some progress for it. You go to the next slide. We finally, go to the next slide. There we go. In June of last year, we finally got it out of the Ways and Means Committee. It's the first time no, go back. Sorry, go back. Great, thank you. In June of last year, we got it out of the Ways and Means Committee. This bill had been introduced in Congress cycle after cycle after cycle. Finally, after 12 years, we got it out of committee. We were looking forward to it. It was still kind of stalled. We were advocating for it. And then finally, the day right before Thanksgiving, on November 26th, President Biden issues a proposed rule, which is basically a regulation that obesity medications will be covered by Medicaid and Medicare. This is a huge, huge victory. I remember seeing the news of this and I was just like ecstatic by this. I'm like, if this is sustained, this can really be a game changer for many of us. So the challenge was, of course, after the election, what's going to happen? So we were trying to mobilize more support from the public. A lot of us reached out to our, like for LULAC, we reached out to our local councils, we reached out to our local community partners. 20,000 letters came in to CMS to try to advocate for this. And the rule will basically include anti-obesity medications into Medicare Part D and also into Medicaid. If it holds true, then Latinos could actually, who are on Medicaid, could actually access anti-obesity medications and actually reduce that 50% of adults, Latino adults who are obese, or that 30% of Latino kids who are obese, can actually reduce that number down. And I'll close with this final story. So I talk about the next slide. I talk about a lot about the situation of my mom, and one thing I always like to pride myself on is we come from a family of pretty good genes. And my mother's grandmother lived up to 102 years old. My mother's maternal grandmother. My mother's mother lived up to 109 years old. Both of those two ladies grew up in the rancho in a small little village in Mexico with no running water and no electricity. Mom was born in South Texas, largely grew up in the US, working two jobs, doing everything she possibly could to raise a family. She died at 73, 35 years less. It doesn't make any sense that somebody who could grow up in a country that has running water and electricity could die 35 years less when they have all the luxuries of a first world country. And so the question is it doesn't have to be this way. I mean, the issue is it doesn't have to be this way. And I think we have a chance to really sustain this. So right now, the outlook is we have till basically late March, early April for the new administration to basically sustain the rule, the proposed rule. If it gets sustained, then it becomes policy. But to get there, we really need to push our our congressmen, our senators, to basically remind them to say this really matters. We don't know what's going to happen with this proposed rule, but if it does stay in place, it will help out a lot of people. And if folks need more evidence of this and need letters, I'm happy to help draft those. There's a whole 20,000 letters in the public record right now of people offering testimony of how important these drugs are for their lives. So again, I can't stress this enough. So again, thank you.
Thank you so much, Dr. Serrano, for this wonderful presentation. And now let's start with the question and answer session. And it will be brief. So let's start with some questions from our members at NHCOA's membership program. And the first is addressed to the topic regarding healthcare providers and also about the cardiovascular disease. But I believe, Christina, you can also jump in, and Dr. Serrano as well. So the first one is NHCOA's research has highlighted specific attitudes and behaviors among Latinos regarding cardiovascular disease. And how can healthcare providers better address these cultural attitudes in clinical settings to encourage preventative measures and treatment adherence? I can go first. I can mention that one that I believe I mentioned in Christina as well is the language and communication. We need to understand that most Latino older adults prefer to communicate in Spanish with their healthcare providers and overall as well. So again, healthcare providers, it would be great if just to know more than one language and or have bilingual staff available, or also if they need medical interpreters that can be in that appointment with someone that prefers to communicate in Spanish, for instance. And also we can highlight that explaining medical concept terms, it can be difficult for the patient to understand. That's why it's very important for the healthcare providers to use clear and simple language when explaining medical terms or like diseases, for example. And other that I can mention is like emphasizing a lot in preventative care. And this is because some Latinos may prioritize seeking care only when symptoms have arisen or they have that disease rather than focusing on prevention. So again, healthcare providers should educate patients on the importance of regular checkups, visit them on a regular basis, not when they're sick or getting sick, and like screenings and vaccinations, and, preventing serious illnesses. Christina, I don't know, you want to add a little bit more?
Yeah, one of the other things that I would recommend is that many Latino cultures emphasize family and communal decision making. So, encouraging family members to attend health appointments or educational sessions can help reinforce those healthy habits and ensure consistent support for preventive measures. The more that your support systems hear how important this is, the more wraparound support a person will have when they leave a provider's office. Another thing that I think is incredibly helpful that we've seen here in Kansas, and Dr. Serrano did a really nice job of modeling, is incorporating storytelling and personal testimonies into your practice. So, using relatable success stories or stories that can illustrate how preventive practices can improve someone's well-being. These personal narratives are a lot more likely to resonate with your patients and with the people that you're interacting with than impersonal statistics that maybe are not as relatable for individuals.
Absolutely. Thank you, Christina. So I have a final question, and this is for you, Dr. Serrano. And it is, how can healthcare policy focus on not just treating obesity, but also addressing its root causes, such as food insecurity, the availability of unhealthy food options, and limited access to safe spaces for physical activity in Latino neighborhoods?
I think, I mean, there it's hard because it's so siloed, right? There's like you have the divisions of like I used to work at the World Health Organization. I remember we would do issues of obesity, we would do issues of like road traffic safety, and like you'd have like different like the Ministry of Roads would not talk to the Ministry of Health, it would not talk to the Ministry like to get everybody in the same room. It was just impossible to talk. But I think so. Sometimes you're always trying to look for that glue that can bring people together, that puts health at the forefront, and really, and everything has to be geared towards that. I think the good model for that has been the environmental impact assessments through the EPA, which Lord knows what's it looking like now, but I know that like but health impact assessments, I think is a tool that Latino communities should be advocating for. Like if they're going to put a McDonald's in your area, what is the health impact of that McDonald's? If they're going to build a new park or they're not going to build a new park, what is the health impact of not building that new park? There should be some consideration of what those upstream factors are because we will see them downstream. So I'm a huge fan of health impact assessments, and I think to have to build health in all areas is something that I think we need to start thinking about more critically, especially as Latino advocates. We all need to start thinking about what resources, what policy tools we can use. And I think again, I can't stress health impact assessments enough because it's not the problem of the doctor visit, because at that point that person is already obese, they already have diabetes, they already have hypertension. It's the upstream factors, the food environment, the built environment, where people can play, people can go walk, where they can go for if they feel safe in their neighborhood to even go for walks. All that matters. And so again, health impact assessments, I couldn't stress this enough.
Thank you, Dr. Serrano, and thank you, Christina. So as we wrap up the question and answer session, we just wanted before, and also before ending today's webinar, we would like to introduce Robert Bob Blancato, who will be providing closing remarks. Mr. Blancato is a member of NHCOA's board of directors and also the president of METS Blancato and Associates in Washington, D.C. He also serves as the executive director of the National Association of Nutrition and Aging Services programs, among others. So welcome, Mr. Blancato.
Thank you, Christina. Can you hear me?
Yes, we can.
Okay, we're having a little trouble connecting here, so thank you, Chloe. Good day, everyone, and it's great to be part of your legislative breakfast. Let's go to the first slide, if we could. And thank you, Dr. Cruz and Christina, for putting this important together. I will be talking about some very current topics relative to policy. And, you know, we are in the second month of this exhausting new administration. But now Congress is going to start to take the spotlight because starting tonight, it will be acting on its budget resolution. And, you know, I was asked to focus on key issues that Congress needs to prioritize concerning older adults and health. And as Dr. Cruz and NHCOA are noting, the priority must be to avert the level of cuts that are being proposed in the budget for at least two programs, Medicaid and the Social Services Block Grant. A basic reality is we are playing defense now. We are not playing offense for a bit of time. Next slide. This is all about saving Medicaid. It is a lifeblood program for millions of Americans of all ages. The House is considering its budget resolution actually tonight. It assumes up to $800 billion in cuts in Medicaid alone. But who is it going to impact? So many different groups of people. 60% of nursing home residents who are in Medicaid. Increased waiting lists for home and community-based services. 10 million dual eligibles who rely on Medicaid to pay Medicare premiums or out-of-pocket costs. 92% of non-disabled working age adults on Medicaid work full or part-time. And another thing to keep in mind, I'll come to this a little later, you have 11 Republicans in competitive seats that represent larger than average Medicaid populations. Combined, that's over 2.7 million Medicaid recipients. Next slide. So this is not only the week, this is the day to reach your House members. As NHCOA is saying, we have to stop these devastating cuts. There are two approaches being considered, cutting federal funding or cutting enrollment or services. Both will hurt. What could hurt Medicaid the most is switching to a block grant or putting per capita caps on how much the state gets from the federal government in Medicaid. We don't have all the specifics, but we're going to know them very soon. So next slide. It's very important to educate your members of Congress about these cuts, to educate them about the impact these cuts are going to have on where you and where they live. Okay? If it was only about cutting waste and fraud, it would be more acceptable, but it is much deeper than that. Don't accept and don't let them give you the argument that they're only trying to get Medicaid to those who need it the most, because everyone who's on Medicaid needs it. Let's not forget that. And reforms of this kind are cuts, pure and simple. Next slide. We have seen already that the grassroots have been awakened by activities from this administration. But this Medicaid situation can only be stopped if we raise our voices. We have heard stories about the Capitol switchboard where people call to talk to their members of Congress had to close recently because they had too many calls coming in. And if the strategy of this administration is to flood the zone and then flood it again, let's do the same thing. Let's flood the phones and the emails of Congress against the cuts in Medicaid. Remember, the House has only a 2-vote majority, and there are several Republican seats where Medicaid is hugely important, and they will be key votes if enough voices are raised in those districts. Next slide. I want to also take a second and reference another program that is under serious threat, the Social Services Block Grant, which is the main funder of adult protective services. It helps prevent elder abuse. And it also provides Meals on Wheels for over 250,000 older adults. In the House budget that's being talked about tonight, they're calling for eliminating funding for SSBG. So your simple message on this one is to save SSBG. Next slide. Quickly, some other priorities that we know are important for older adults and health. Reauthorizing the Older Americans Act. That was almost done last year. We have a good bipartisan bill from last year that could be passed quickly if we push hard. Extending the law for 4 years with funding increases to allow us programs that provide nutrition and caregiver services and employment preventative health, elder abuse prevention, and more to continue and grow. But most importantly, the services in the Older Americans Act are targeted to older adults in the greatest economic and social need, including low-income, minority, and limited English-speaking older adults. We need to get the Older Americans Act done soon. Next slide. We also have to think about the funding for the rest of this fiscal year. It could end as early as March 14th. It's important to have Congress pass whatever is necessary to keep programs and services funded after that date. A government shutdown, which could happen, would be devastating, and even more so with the Government Efficiency Commission running wild as they are. They would take full advantage of a government shutdown to wreak more havoc on federal programs and federal employees, and we need to keep that from happening. Two other quick priorities. One, next slide, a family caregiver tax credit, which I know NHCOA has been involved in. We have an opportunity perhaps to pass a first-time family caregiver tax credit. President Trump proposed it in the campaign. A tax bill is being developed where this could be included, but we have to add one condition. If this tax bill is funded by cuts to programs which help older adults and persons with disabilities, we cannot support that bill, even if the family caregiver tax credit is included. This one will have to be watched. Next slide. Something that Dr. Cruz and I work on regularly is vaccine access. We have worked together over the years to make sure older adults have full access to vaccines, and we're worried this progress might be in jeopardy. There was supposed to be a big meeting of the group that advises the Centers for Disease Control on vaccines this week. It was suddenly postponed. The reason that was given to allow time for public comment. Well, we sent a letter, my organization, NANA, sent a letter to Secretary Kennedy asking for this meeting to be quickly rescheduled, because the meeting was going to make the important decisions on vaccines, including RSV, COVID-19, and pneumonia. We all know this has been a tough winter in many parts of the United States, and flu cases are rising. We can't let our guard down and have this new administration weaken our commitment to protecting older adults. Next slide, quickly on this one. You know, you've heard this term of MAHA, okay, Make America Healthy Again. Well, if we're going to do that, let's make sure it includes older adults, and let's make sure it includes a focus on good nutrition as a key element of good health. And then finally, let me just say, from a standpoint of being an advocate, I want to give you some tips about advocacy in the year 2025. Let's not forget that advocacy is a contact sport. It's about being constant, being creative, and being courageous. It's about keeping your eyes and ears open at all times and your heads down when it's necessary. Have your local data and your stories. Don't chase after every rumor or story you might read or see. Wait it out a little bit. This is not the time to stand down. It is the time to show up and be heard. Thank you for the chance to be with you today.
Thank you, Bob. So again, we would like to thank all of our attendees and experts for joining us in today's virtual legislative breakfast. And before we close out today's session, I'm excited to invite you to join us in our individual membership program, where you will unlock exclusive resources to help you grow professionally and also make a lasting impact on the lives of Hispanic older adults. For just $25 a year, you will gain access to educational workshops and webinars, networking opportunities at conferences, career development resources and job listings, and also advocacy tools to support Hispanic older adults and much more. Join us today to connect with like-minded professionals and be part of a community making a real difference. Again, you can scan the QR code that's right here in the slide, or also contact us at NHCOA for more information. And again, for more information about upcoming webinars and events, please visit NHCOA's website and social media platforms such as X, Facebook, Instagram as at NHCOA. Until the next one, thank you, gracias.